All right, good morning. I'm Helen from Indiana University, and I'm thrilled to be here this morning to dig into a topic that we don't always openly talk about, which is how are we actually managing our practices and making day-to-day decisions on patient care. Often at these meetings, we talk about the latest science and surgical techniques, but how does that actually translate into what patients are making or how decisions we're making for patients on a day-to-day basis? Like if a patient comes to see you with prostate cancer, are you prescribing them testosterone? Or how do you manage Peyronie's disease when placing an IPP and he has residual curvature? So today we're gonna flip the script and we're gonna poll you, the audience, the SMSNA community, to get a real-time snapshot of how we're managing patient care. So there's no right or wrong answers. This is all to learn and hear what everyone else is doing. So go ahead and get your phones ready so that you can scan this QRS code next so that we can have you participate. These are my disclosures. I'm a consultant and a grant recipient for both Boston Scientific and Coloplast. All right, so get ready to scan your codes. You'll have about 15 seconds after each question to make an answer, and then the audience responses will generate. All right, I think everyone's got it. In addition to you, the audience, we have this expert panelist. They're going to be here to offer guidance and insights into our questions. We have Dr. Carolyn Salter, Associate Professor at the Uniformed Services of the University of the Health Services. We have Dr. Juan Andino, Assistant Professor at UCLA. We have Dr. Larry Levine, Professor of Urology at Rush University. And we have Dr. Tammy Rowan, Associate Professor at UCSF, and we have Dr. Christian Nelson, who's the Chief of the Psychiatry Service at Memorial Sloan Kettering Cancer Center. So without further ado, let's get started. So when you implant an IPP and you see the patient still has a residual 40-degree Peyronie's curvature, what do? Manual modeling, plication, plaque incision and grafting, plaque incision plus or minus grafting, or nothing. Here we go. So the overwhelming majority would do manual modeling. Dr. Levine, what do you think?
Well, I think 71% are right. The first approach I would take in this situation, well, first of all, if he had a little deformity that you didn't know about in the first place, you might get some sense of that when you are getting ready to do this surgery and you're prepping him. I do instill about 60 cc's of a mixture of 1% lidocaine and saline at the beginning of the procedure. I think this enhances some local anesthesia. It facilitates mechanical dilation, and you get a chance to see, is there some deformity there that you didn't expect. But if you didn't see that, and you then at the end find this deformity, I think modeling makes sense. I do that pretty routinely, and I would say that when I see patients preoperatively and I know that they have a deformity, I can say with pretty good confidence that I can get reasonable a correction of their deformity. I call it functionally straight, 20 degrees or less in any direction with manual modeling if their curvature is less than 60 degrees and they don't have a good deal of plaque calcification. So manual modeling would be the first approach I would take.
Excellent. All right, what is your first-line medical treatment for delayed ejaculation? PDE5 inhibitors, testosterone therapy, ADIA, sexual therapy, or you don't prescribe anything to these patients? Looks like PDE5 inhibitors followed really closely by sexual therapy. So I probably do both as well. What do you do, Dr. Andino?
Yeah, that's exactly what I was going to say. I think combination of A and D is going to be efficacious, particularly if they have erectile dysfunction, a component of that. And the hard part, which I'm sure other folks on the panel can speak to, is that you can talk about sexual therapy and offer it and give people websites and phone numbers, but the follow-up and continuation of that with the issues around coverage and cost can be very challenging on the patient side.
Yeah. I have tried Adia in a select few. Does anyone on the panel prescribe that to patients?
Which medication? The Addy? Yeah, so Addy is flibanserin is the generic for that. So flibanserin is a mixed serotonergic agonist-antagonist, and it works. It's been studied for hyperactive sexual desire disorder, specifically in it's approved, FDA approved for premenopausal women. It works in postmenopausal women as well, and it should work in men as well, considering the neurologic pathways are quite similar. The dopaminergic and norepinephrine pathways are similar in both brains. We use it mainly for desire, as opposed to, if I were to think on the female side of what delayed ejaculation is, would be more female orgasmic disorder, delayed orgasms, muted orgasms. Again, it wasn't studied ever as a clinical endpoint with orgasmic dysfunction, but in all of the studies, there is evidence that shows that there are improved orgasms with flibanserin use. The caveats to flibanserin is that it is a nightly medication. It is not PRN, and it can cause a lot of drowsiness. If you combine it with alcohol, it can make you more drowsy. There used to be a REMS on it. No longer is necessary to have a REMS or certification for prescribing, and you don't have to tell people they can't drink alcohol. I usually tell them to avoid alcohol within 2 hours of the medication.
Excellent. Dr. Shindo? Can we turn the mic on?
And obviously, and the guidelines that we have on this condition, I would say A and B and D are all legitimate. B, assuming that their testosterone levels are low. This is a kitchen sink problem where we don't really have a drug. There is no orgasm pill, unfortunately. So I think ADYE is certainly reasonable. And there are other off-label treatments so I tend to give a lot of cabergoline, bupropion, buspirone, dopaminergic drugs as being potentially useful, but there's no silver bullets, there's no great solutions. Patients have to be informed of that this is a tough to treat condition.
Thank you for your comment. So moving on.
Can I just make one comment? One agent that wasn't listed that there is a publication on that was with myself and Matt Ziegelman and his wife, who was a psychiatrist, was using Adderall for men with delayed ejaculation, treating independent delayed DE only. And we actually showed a reasonably significant signal of improvement. About 40% of the men who had significant delay in ejaculation had improvement of ejaculation. The sweet spot seemed to be 10 milligrams taken an hour before anticipated sexual activity. It's a PRN agent, and I would suggest that you give it a try. We actually did a pilot study. We're piling up our data at this point. Clearly, there's no placebo-controlled trials on this as of yet, because the numbers of patients are relatively small, and this would require, I think, a multi-center approach. But it does make some scientific sense because it is focusing the brain. We found in a study that we did at the same time, a validated study on ADHD, that a lot of these men have ADHD like symptoms, and so maybe their minds are wandering and things of that sort, and they can't focus on the task at hand. So this type of agent may make some sense.
I would also just add that the mechanism of action is on dopamine as well, and since dopamine is the major neurotransmitter in desire and orgasm and sexual pleasure, that's the other biological plausibility for Adderall. It's the same explanation for why flibanserin would work.
Excellent.
Not to kill DE, but we see patients who have DE and maybe low back pain and sciatica, which is not uncommon in aging people, and we get lumbar MRIs, and we have found that the DE is really a consequence of a delayed neurologic information to the brain. So we would treat that, but
thank you, Dr.
bring that
Paulson.
up.
All right, when you have a patient post-radical prostatectomy, you're pacing a penile implant in, which approach do you use for reservoir placement initially? All right, it looks pretty split here, almost a 25% all the way down. I almost always initially at least try a spacer Dr. Salter, what do you do?
I'm a big fan of doing the counter incision, and I know some people think that that really adds to the patient pain post-op, but I'm lucky enough to have liposomal bupivacaine that I can use in my patients, and so I've never had anyone be bothered by the counter incision. I don't think it adds a lot of time to my case, and I'm a pretty low volume implanter, so it just makes me feel more comfortable.
Anyone else? All right. Are you treating male and female sexual dysfunction in your practice? I try. All right, so the overwhelming majority isn't. Now, a raise of hands in the audience. How many of you are at least asking your patients if their partners are postmenopausal or on vaginal estrogen? Good, good. Dr. Rowan, what do you think?
I think that it's interesting that that's the first question we would ask. Are they postmenopausal and on vaginal estrogen? Because the question I would ask is, does your partner have any sexual dysfunction? That's what I ask my patients. And I wouldn't necessarily get to that because someone's necessarily postmenopausal and on vaginal estrogen. But I think that that's really the key. So when I don't treat men, I treat women, or I treat trans men. I do a lot of gender affirming care. But I have a kind of set of questions I ask people, and at the bottom I always ask about their partner. What's going on with your partner? Do they have any sexual dysfunction? What are their goals? In female sexual medicine, what we see is desire discrepancy, where a lot of women come in saying, I don't have desire, I'm okay with that, but my partner isn't. And that's where I really have to start talking about getting psychologists involved, because that's not HSDD, right? That's actually a desire discrepancy. But many of my older patients have partners with sexual dysfunction, and that's why it's really valuable to get familiar with the male sexual dysfunctions, because OBGYNs don't know anything about what goes on with men and their sexual health.
So I think we all have room for improvement. Dr. Goldstein?
Yeah, I just want to announce to everybody, but the AUA put together a GSM guidelines, and it's coming out at the AUA on Monday morning. So hopefully next year when you ask this question again, at least based on we are now having guidelines to manage this, you'll see a 50-50 thing, I hope.
Excellent. And a man treated with intermediate prostate cancer with no evidence of recurrence of disease for over a year, are you treating their low testosterone with testosterone therapy? So the overwhelming majority. Dr. Andino, do you also treat?
Yeah, I completely agree. These are excellent numbers to see. And Dr. Kara, Dr. Morgenthaler's work in this space and really looking at the data, highlighting the safety has been critical. I still try to kind of load the boat if they have an oncologist, especially internal, that we can communicate back and forth. Just talk to them first and make sure that they're not going to freak out and then point fingers if the PSA goes up or something happens. But I often review that, there's always a risk of biochemical recurrence and progression down the road, but it is not the testosterone, it's their cancer, it's a disease.
I would just add that I would treat these patients theoretically the day after surgery. If indeed you've done a successful operation, you've removed their cancer, you're confident that there's no residual disease, which of course we can't be confident of, but if theoretically, if there's no more cancer, then we ought to feel comfortable resuming a testosterone replacement therapy at that time. So, when I started my career, it was never, then it was, well, we'll wait 5 years, and then it was 3 years, it was 1 year. I think we can wait until we see maybe the first PSA, and if you're confident with the pathology, again, you have conversations with the patient, assuming they have symptomatic hypogonadism, I think it's reasonable to consider treatment. And then the question is, well, what if you create a monster? If the PSA starts to go up, you stop. So it doesn't turn it into a cancer that will just take off. And in fact, some people would even suggest that it might be provocative, that you might identify residual prostate tissue and know that you're going to have to address biochemical recurrence at a minimum.
That's a good point, because we know that PSA is an androgen-dependent molecule, and as a result, if your testosterone is very low, you may have a falsely low PSA as you're monitoring these patients. Just for purposes of trying to get through some questions, I'll come back if that's okay to some of the questions. How do you manage isolated hourglass deformity in men with Peyronie's disease? All right, so extratunical grafting and Xiaflex. Dr. Levine, do you have comments on this?
Well, a lot of it depends upon the severity of the hourglass deformity. If it's associated with hinge effect, my opinion, you probably have to do a partial plaque excision and grafting to reestablish a more normal caliber shaft. If they do not have instability, then I think extratunical grafting is, I think, my procedure of choice. But before doing that, I would certainly give a trial to traction therapy. I think it's been well shown that traction does cause cellular proliferation in all dimensions. And so when I first started doing traction, patients would come in and say, "Hey, doc, you remember that little indentation I had there? It's filling in." Oh, this is the practice of medicine. We learn from our patients. And so start with traction, certainly, and then work your way up potentially to a surgical remedy.
Dr. Liu?
Yeah, since I started the extratunical grafting, and I have done a number with the CCH, I think in a mild case with a CCH, and then you don't put on vacuum device, of course, you get very swollen. But after 2-3 weeks, you can start the patient on vacuum device. It can be helpful. Whenever you have an hourglass deformity, usually you involve two places, the dorsal and ventral. If you examine the patient carefully, so if you dissolve the ventral and also the dorsal curvature, you may actually expand the hourglass deformity. But usually I will follow after 2-3 weeks, we'll do the vacuum device to help expand it. Now, if it's a severe case, I think it's better to do the extratunical grafting. And if you don't open the tunica, the impotence rate is literally 0. So I think this is still a very good way to do it, and it's minimally invasive. I think this is a good one. I agree with the audience. This is a good operation, right?
Do you get any female sexual health training? Dr. Rowan?
Wow. I mean, it's interesting. As a medical student, I have to say I did not do the urology rotation because I assumed that it was only in men, and I ended up marrying a urologist who reminded me that it actually is both men and women. And so it's been really interesting going to these meetings and realizing that it hasn't changed basically in terms of who people are focusing on, but that women actually are the have a urologic system that actually affects sexual medicine or sexual health, and that sexual medicine was started by urologists. I mean, I have to give credit to Irwin Goldstein, and my understanding of how it started was when we started focusing on men, it actually allowed women to say, "Hey, wait a second, is there something for me?" And we became more attuned to the fact that this actually had a role in medicine. So I give a lot of credit to the urologists for really creating the field of sexual medicine, yet it's still fascinating to me that people who specialize in sexual medicine get so little training on women. And I understand there are people who don't have sex with women, but most of your patients do. And most of the problems that you're dealing with have analogous problems. The problems in men, there are analogous problems in women. There's actually similar mechanisms. So I think it's critical, and as we are well aware, most people who are in sexual dyadic relationships are going to be with somebody who's a woman who may likely have a sexual dysfunction as well. So at least getting familiar with it is going to make you much better able to take care of your men. But I would also argue that it's incredibly satisfying to take care of female sexual health problems as well. It is a really wonderful area of medicine. There are surgical procedures involved for a surgical field, just so you know, and you really make lives incredibly better. You see it in men, but I promise you, you'll be even more overwhelmed if you take care of women also.
Sue?
Shout out to the AUA. They've had a course here at the AUA since 2004. Because Irwin's taught an FSD course every year, and the last few years have been multiple courses. So, there's opportunity for you to learn, and if you want to learn at a deeper dive, come to the ISWISH Fall course. We have the in-person fall course. We have online training courses. It's free, by the way, to trainees to join the society, but there is content out there. I know that, AUA is providing you small pieces, SMSNA is providing you small pieces, but if you're interested, there is information out there. And as Dr. Rowan said, it's such an important part of your practice, even if you're only seeing men, to have an understanding for what their female partners could potentially be going through.
And just to add, I want to say if I were at ACOG, the American College of OBGYN, we'd get the exact same response as we got here in the audience in terms of training.
I teach the IU medical students their sole lecture on sexual dysfunction out of their 4-year medical school, and it's a 1-hour course that I split with an OBGYN to teach about male and female sexual dysfunction. So we have a lot of room for improvement. Now, what % of patients who have psychological factors that when they come to see you for a sexual health concern, do you actually refer to a sexual therapist or a mental health counselor in your practice? All right, about 30% do it almost all the time. Dr. Nelson, what are your thoughts?
So those numbers are higher than I thought. So excellent. It's good to see. I just want to address the comment that sometimes when you refer, it's difficult potentially to connect with someone in your community, our coverage. And so some things to potentially help with that in terms of finding a psychologist or a sex therapist to work with. One is I just think it's really important to reach out. It might take some upfront work, but hopefully it's really worth it if you then connect with a few providers in your community. But actually reaching out to them and actually them inviting them into your practice so they can come and sit in with you for, let's say, an afternoon or a day can be extremely effective in just helping them understand the types of patients you see, but then also helping coordinate that care in the future. So one is reaching out and be active. And the other is the Sexual Medicine Society in North America is increasing kind of the volume of sexual medicine or mental health professionals kind of in the society. And we've now established a database with those providers that SMSNA medical professionals, neurologists, can then access and see who those people are. And so hopefully what we're doing is we're trying to do a better job in society, having those mental health professionals available, come to our conferences, and then having a chance for you to connect with them.
What's a good resource that urologists and providers in the room could find a mental health provider or sexual therapist?
So STAR is a really good resource, and ASAC. So STAR is the sex therapists and research group, but ultimately they're sex therapists. A lot of them are clinicians, and they have actually a really nice website and a really nice kind of list of their providers by states and then by communities. And then ASAC also has a very nice list. Again, sometimes it's difficult to reach out, and that's where connecting with them and having them come into your practice, trying to establish relationships are really helpful.
Excellent. So we might have time for about one more question. What is your preferred penile implant approach to rear tip extender selection? Do you always use as few as possible? Do you use none, only the amount you need, or you just switch it up depending on the patient? So as few as possible or only amount needed. I think that's probably the majority, over 75% of patients. So let's try to get through one more question. How often have you been sued in your career in sexual medicine? Topic we don't talk about much, but happens.
It's an interesting question.
All right, so about 20% of patients have been sued at least once, or 20% of providers. Any comments from the audience? Or the panelists, sorry.
Well, getting sued is a bummer. There's no doubt about that. Whoever's been sued 3 or more times, please stand up. I was sued during one of my first years in urology, and it was because we were using a particular type of prosthesis at the time that we used some half-strength contrast, and I didn't realize, but the scrub tech had made it 100% contrast, which is sort of hydrophilic, and the reservoir kept filling. We kept on getting this auto-inflation thing, and it wasn't until I took it out and I did an analysis of what the fluid was that we determined that, and then they sued me, which I then got dismissed from. But it is a distressing process, and anytime we have a bad outcome, it hurts. I mean, you don't sleep well, your days are bad, you feel awful, but this is medicine and this is surgery, and things happen. So I think we have to be prepared for it, and I think we all know the right things to do in terms of interacting with our patients, and proper documentation will usually keep you out of trouble.
Dr. Kohler.
I'd say the most important things to avoid lawsuits are, number one, talk to your patients, know them before you operate on them. So under promise, over deliver. Especially when you first start out, you're excited to do surgery. You tend to, kind of de-emphasize the things that could possibly go wrong. You want to do exactly the opposite. And then most people get sued due to lack of communication, not because of a bad outcome. As soon as a bad outcome happens, our tendency is to hide, put the head in the sand, and not think about it. That's the worst thing you can do. You have to demand to see that patient more and more, and put more time and effort into that care, and likely you'll get away with it. It's people who ignore it, they're in trouble.
All right, let's give a round of applause for our expert panelists and for you, the audience. Thank you.